It's my great pleasure to introduce Dr. Bruce Lanfield to kick off the fall 2024 seminar series in the Philadelphia Regional Center for Children's Environmental Health. Bruce is a physician and professor at Simon Fraser University, British Columbia in Canada. He led influential studies to examine health effects of lead exposure at levels below CDC's level of concern was at 10 microgram per deciliter, but then reduced to 5 and now 3.5 as a reference level. His research findings really used by various federal agencies around the world to set standard for harmful levels of lead in air, paint, water, and dust. His research convinced the public health agencies really to say that there's no safe levels of lead can be identified. He has studied more than a dozen of chemicals and conducted a dozen of randomized clinical trials to reduce environmental exposure on lead paint, tobacco smoke, pesticides, and airborne pollutants. So he founded the Cincinnati Children's Environmental Health Center in 2001, and also the home study was funded by that time. And he's my long-term collaborator for maybe more than almost 2 decades, and we published more than 140 papers together. It's my honor to work with you, Bruce, and welcome you here. So Bruce and his brother actually co-founded Little Things Matter and to disseminate research on toxic chemicals, which is what we do for research to translation. And they produce videos to show our health is inextricably linked with environmental exposures and, really with the goal to preventing disease. Bruce.
It's a pleasure to be here today and share some of my work and many other people's work, and hopefully a perspective that will encourage you to think about things a little different. And if you already think about things this way, then perhaps to encourage you to act on things like prevention. So I wanted to talk about this in the context of the enduring legacy of lead toxicity. And as you'll see in just a minute, I was encouraged to get out of this line of work about 25 years ago by my advisors because the problem was going away. And there wouldn't be any funding, they said. And they were right about one of those two things. Very quick disclosure, I don't get paid for any of the work I do, except I did. This is how I got my first big study. Anybody know what this was about? Louis Stokes, who was a congressman from Cleveland, Ohio. Mr. Speaker, it's appalling that the dangers of lead poisoning have to be brought to the nation's attention through the White House dog. Every day in our nation, 3 million children suffer the effects of lead poisoning. Poor inner city children who live in older buildings are particularly vulnerable. And while he wished Millie well, he also hoped that this incident will bring the problem to a head. 2 years later, the Lead-Based Paint Hazard Reduction Act was passed. And one of the mandates, this was a congressional mandate, was that we needed to have a dust lead standard for housing. That was my first big study as a postdoc. And we really had to address 2 different things. First, how can we measure lead in house dust? And what type of metric should we use? But dust loading was also a viable option. How would we tell the difference? Well, we ended up recruiting 205 families, and it was an extraordinarily challenging study. I was like 32, I think, at the time. We had to recruit 200 plus families. They had to have lived in the same household from 6 months of age to when we studied them. They could not have previously been lead poisoned, known to be lead poisoned. That was in a community where 1 out of 3 kids were lead poisoned. Their parents couldn't be involved in an occupation or hobby that would involve lead poisoning, and they could not take iron. I was presenting this to my research in progress work group as a postdoc, and they said, and you better do it as a random sample. Are you kidding me? We've got to recruit these 200 kids with these exclusionary criteria. We were funded June 1, and we had to be finished by Thanksgiving. 200 kids. We had to collect 36 dust samples, 12 soil samples, 2 water samples, 2-hour visit with the moms, blood draws. And we had to get through all the bureaucratic morass to get there. So how could I do a random sample? Impossible, I said. Well, I went back and thought about it, and it led to what I think is one of the more innovative things I've been involved with. We decided not to do passive recruitment. Now, at the time, and probably still today, that's still fairly typical. Somebody standing with a clipboard waiting to contact people. What we ended up doing is we took all the birth certificates of children born into this city, into Rochester. And then we used housing assessors data, birth records to figure out which ones were eligible. We ended up contacting 2,500 kids to find those 205 families that were eligible and willing to participate. We had 2 people morning, afternoon, evening calling people. But what it meant is that we got to control recruitment process. We didn't have to rely on somebody with a clipboard or a physician who's trying to take care of patients. Each of those red marbles represents a lead particle. Each of the blue marbles represents a dust particle. All right, so concentration is micrograms of lead per gram of dust. Loading, microgram of lead per area. Which one of those do you think, if a child crawled across that room, they'd come into more contact on their hands and then put into their mouths a lead marble, a red marble? Which one of those two, panel A or panel B? They're the same concentration. All you have to do is to multiply it by about 10 and you get panel A from panel B, but they're both 50% concentration. So you get a sense of why loading, at least in this case, was significantly stronger predictor, right? Good. We also found, ours is the blue diamonds here, that if we were to achieve the EPA's own definition of what was an acceptable blood lead level, that we needed to have floor dust lead levels below 5 or 10 microgram per square foot, we said, back in 1996. It took EPA 5 years longer than was mandated, but in 2001, they set the standard for floor dust. I'll use that as an example. We also had one for sills. And they said 40 microgram per square foot would protect kids. At 40 microgram per square foot, we knew from our own research, 1 in 5 kids would be lead poisoned. Wasn't protective. So they used our study, they said, as the main study for their standard, but they misrepresented it because they were overly concerned about what they erroneously thought was feasible to achieve. That has been a typical approach to EPA for decades. To give you an example, the paint lead standard up until 2008 was 600 parts per million. Where did they come up with that? Julian Chisholm led a committee, and they knew that there was too much lead in paint, but they didn't know what too much was. So they opened up a bunch of cans of house paint, and they tested them. They found that there was enough below 600 part per million that was easily achievable. Now that led to reductions, important reductions in exposure to lead from paint, but it was just completely arbitrary. It was based upon what they thought was feasible. This study and several others like it that have been done since ultimately led to the proposal to lower the dust lead standards last summer to what now is based upon the best available science from 1995. And it took 2 federal court cases. This is not unusual. We may have good science about toxic exposures to lead or PBDs or whatever, and yet it takes oftentimes the legal system to get involved. But still, 25 years later, almost 30 years later, I can at least now begin to say, maybe I could retire because the study I did 30 years ago has now finally been put into place. At that time, and some subsequent analysis that Adam Spanier, who was also involved in the Cincinnati Children's Environmental Health Center, has done, we were able to come up with a way to estimate the relative contribution of these various sources of lead in a child's environment. But there's caveats. This is for a typical 2-year-old child that we had followed from 6 months on. This was for Rochester circa 1996. It probably is reasonably relevant for Philadelphia, but maybe not other cities where the primary source is lead contaminated water. But we don't have any better, more recent studies than this, which is kind of strange because every time we go talk to the EPA about standards or when I'm on the science advisory board, we say, okay, Where's the new evidence? What are the relative sources, or relative contribution of various sources circa 2022? And, you know, you're on the SAB and you say, well, somebody needs to do these studies, EPA, or somebody needs to fund these studies, EPA or NIH, but it's all left up to an individual investigator to decide to do it. We don't have a systematic approach to address these kinds of problems, which never made any sense to me. Well, in the midst of all this, as I said, we saw blood levels coming down. And my advisor said, the problem's going away. But I was still concerned because in cities like Rochester and absolutely like Philadelphia today, which is one of still the epicenters of lead poisoning in the country, I could look around me in 1995 and see that 1 in 3 children still had blood levels above 10 microgram per deciliter, even though 5% nationally had blood levels above 10. So I wasn't quite ready to abandon my work on lead poisoning prevention. If you look at the concentric circle in the middle, 1 in 2 African-American kids had lead poisoning. And so the other thing that hadn't really been addressed is 10 microgram per deciliter or 100 parts per billion of lead in blood really protective? Many of the older pediatricians were absolutely convinced it was because they all had blood levels above 10 and they'd seen such high blood levels. How could it be that levels that low were harmful? Now, I'm going to flip back and forth a little bit between microgram per deciliter and parts per billion, partly because I'm going to try to convert you all to using microgram per liter instead of microgram per deciliter. And microgram per liter is equivalent to parts per billion. All you need to do is add a 0 at the end of, instead of 10 microgram per deciliter, it's 100 microgram per liter. So why would we do that? All the other metals use microgram per liter. It's easier to convert microgram per liter to parts per billion. It's easier for people to understand parts per billion. About 1 or 2 tablespoons of sugar, let's say, in an Olympic-sized swimming pool is 1 part per billion. You can kind of get that, even though it's still kind of hard to get your head around, just like it's hard to get your head around is how much is $1 billion bills. Anyway, but you get a sense of it. So before abandoning this area of research, we started to ask some questions, and quite naturally, we went after some readily available data. It's cross-sectional, so it has those limitations. But what we found is, beginning at the lowest measurable level, we saw steep decrements in reading ability. Reading, of course, is very highly correlated with IQ. And this would be called the decelerating dose-response relationship. Starts off steep, and then it decelerates or attenuates at the lower end. Now, I didn't, to tell you the truth, really appreciate this. It kind of went over my head. I mean, as a physician, I was trained there's safe levels of these chemicals. I thought kind of linearly. So this is something I did after the fact. But then we saw the same thing in a longitudinal cohort study that I'd assembled in Rochester. Now we're using IQ. Now we're adjusting for parental IQ and many other factors. And what we see is the same pattern, steep decrements. Now, in this case, in IQ or intellectual ability at the lowest levels, and then it attenuates. So in this case, the first 10 microgram per deciliter or 100 parts per billion was associated with about a 6 to 7 IQ point decrement. The second 10 microgram per deciliter increase, about a 2 or 2.5 IQ point decrement. And the third increase, about a 1 IQ point decrement. Seems a little bit counterintuitive, but we kept seeing that same pattern. And even though by 2003, I was convinced, it's easier to convince people if you run the study yourself, right? It's harder to convince other people in large part and too often, unfortunately, because they don't bother to read the goddamn studies. It's easy for people to throw out opinions. Now, for example, I can't tell you that climate change is a big public health issue. Well, I haven't bothered to look. I've been so heavily focused on lead poisoning prevention, so I shouldn't espouse anything. I should rely on the independent scientists. But too often people are willing to say, oh, I find it hard to believe. Read the studies or just keep your mouth shut. Well, So we looked at this, and one of the things you can see, the intercept, of course, differs quite a bit in Boston, which represented the children of professors and physicians at Harvard and MGH, started out much higher than the group in Rochester, which was inner city and some more affluent children. It was a mix. But people looked at the slopes across these different cohorts from around the world, and they said, they're all over the place. They can't be real. Well, pooled analyses, we got all the raw data, put it together, and they aren't always quite so magically revealing, but I was just so impressed with this. Because what happens when you pool those data? All of a sudden, those apparently discrepant slopes make sense. Let me go back a minute. Boston and Rochester, the populations were dramatically different, but the range of lead exposure that they were at the lower end of lead exposure, were similar. And so that's why we were seeing in both of those two disparate cohorts, steep decrements. This has been confirmed in over 12 studies that looked carefully. It's been confirmed when you use plasma lead instead of blood lead, which is a harder measure. It's been confirmed when you use bone lead levels, which is a stronger, better measure. So all of these estimated reductions in IQ, because we relied on blood lead, are probably an underestimate, which is kind of scary to think about. Amin mentioned that my brother and I have been working on some videos. This is our social media program called Little Things Matter. And this is a snippet from one of our earlier ones.
Most of us have IQ scores that fall between 85 and 115 points. Only 2.5% of children have an IQ above 130, which is considered gifted. There are about 6 million children in this group. On the other end of the distribution, another 2.5% of children have an IQ below 70, which is considered challenged. The impact of exposure to a toxin like lead causes a 5-point drop in IQ. This shift results in a 57% increase in the number of children that are challenged, from 6 million to 9.4 million. There is a corresponding decrease in the number of children that are gifted, from 6 million to 2.4 million. Little shifts matter. The impact of exposure to another toxin, like flame retardants, results in a further increase in the number of children who are challenged, from 9.4 million to over 11 million. There is a further decrease in the number of gifted children.
And of course, the real problem is it's not just lead and PBDEs. Air pollution has been associated with cognitive decline. Pesticides, some pesticides have been associated with cognitive decline, and many of these are ubiquitous exposures. Not all children are exposed to higher exposures, but all of these exposures are ubiquitous. The other thing we know is that toxic chemicals that have a detrimental impact on early life IQ have persistent effects. That's been shown certainly with lead. There's no reason to expect that a 5 or 10-year-old child's IQ isn't going to persist. That doesn't mean that you can't begin to try to modify it or ameliorate it, but it's going to have lasting impacts. So we've all been lead exposed, so that's the upper line there. And so what typically happens is that children have an increase in their cognitive abilities that increase into the 20s. They tend to stay at that peak level for about 20 or 40 years. It keeps getting longer the older I get. And then it starts to decline. Now, is that decline natural or evolutionary? I don't know, but it certainly is part of our industrial heritage. So that accelerated decline, and then at some point, children with higher lead exposure don't mean the same peak cognitive ability as those with less exposure. And at this end, 2 studies, one in the normative VA aging study and one out of Johns Hopkins, show that if you have higher bone or blood lead in 60 to 65-year-olds, you're going to have accelerated cognitive decline. And in theory, but this hasn't been shown yet, meet the threshold for dementia sooner. So as Amin mentioned, in 2012, the CDC recognized that there was no identifiable safe level. And yet it's worthwhile to point out that if you go back to the 1970s, when lead exposure was much higher, leaded gasoline was still being used, the typical lead poisoned child, each of those dots represents 40 micrograms of lead in bone. So 40 micrograms of lead in bone, not in blood, it's a concentration, but it's in bone. The middle child represents a typical child circa 1960, 1970. The child on your far left represents a pre-industrial human, a pre-industrial child with 1 dot. So even though blood lead levels have come down by 95% since the 1970s, our blood lead levels, our children's blood lead levels are still 10 to 100 times higher than our pre-industrial ancestors. So I'm not sure we can say we're there yet. We may continue to see deficits, and some of the studies I'll show in a minute or two suggest we might continue to see harms at lower and lower levels. For example, this was a study out of the ALSPAC cohort. Carolyn Taylor and her colleagues found that pregnant women with a blood lead level over 50 parts per billion or 5 microgram per deciliter were almost 2 times more likely to deliver prematurely. Last year, Mandy Fisher and the MyREC birth cohort in Canada found that a 10 part per billion increase, that's equivalent to close to 0 to 1 microgram per deciliter, a 10 part per billion increase in blood lead was associated with a 50% increase in premature birth. But wait, there's more. This is the first time this has been looked at in as a modifier with low vitamin D. About 15% of women in the MyREC cohort had low vitamin D levels. And in those women, we found that a 10 part per billion increase was associated with a 3-fold increase in preterm birth. So what do we do about this epidemic of preterm birth, of premature babies? Build bigger NICUs. Isn't it obvious? Now, of course, lead's contribution in North America to preterm birth is likely coming down. Other factors are leading to an increase in North America, but lead might be contributing mightily to an increase in preterm birth around the world, where 1 in 3 children qualify as being lead poisoned. 90% of those in what many people call low to middle income countries. I like to think of them as industrializing countries because that gives you a clue as to why we have so many of these problems. It's not because we have low income necessarily, some of that is true, but because we're, in many cases, at least as I'm presenting it here today, we live in an industrialized society. But this is I wanted to mention very briefly a study that Ellen Silbergeld did in 1974. Ellen Silbergeld was really a genius in many ways, and she was often like one of her favorite toxic chemicals she studied, quite mercurial. She, from one time you visited with her to the next, one time she was like a generous aunt. Another time she would be berating me for not doing enough research on adults. Why aren't you doing anything about adults? It's hard enough just focusing on the children, Ellen. Well, Ellen did this really interesting study back in the early 1970s. She wanted to understand why workers who had lead poisoning had a palsy. And so she took some mice and she injected them with lead. And of course, she had a comparison group. And she saw something that was really quite amazing. The rats that she'd exposed to lead were all over the place. They were hyperkinetic. They didn't stop moving. And she told her sister about this. Her sister took care of kids who were developmentally challenged. And her sister said, well, what happens when you give them methylphenidate? That's what kids are still sometimes treated with today for ADHD symptoms. And Ellen said, I don't know, but she did it. And it calmed them right down. So this was 1974. Herb Needleman used this, among other research, to do what many of us think in this field as the seminal study of childhood lead poisoning. And what he did is he recruited over 2,000 school children in Massachusetts, paid to have substitute teachers come in so the teachers, the homeroom teachers, could evaluate these kids on a whole range of behaviors. And then, of course, unbeknownst to the teachers, they measured how much lead was in the baby teeth. Now, most of you probably know this, but why would you bother to use teeth? I kind of already gave you a clue to measure lead. Why didn't they just use blood? Perfect. So most of the lead in our body is stored in our bones. For adults, it's about 95%. For children, it's estimated about 70 to 75%. And the teeth, of course, are a type of bony tissue. So teeth act as a cumulative biomarker of exposure. And so baby teeth which is what Herb Needleman used. And there is work that Manish Arora is doing at Mount Sinai School of Medicine, where he's even trying to be more precise, just like you can look at tree rings. He can give you week-to-week measures of lead exposure in utero. So there's some really powerful, now that's still very expensive. Blood lead is adequate for sure as a population level measure, but it's likely to be underestimating the problem. One of the things that Tanya Froelich did as a result of some of those studies I just mentioned was she used the National Health and Nutrition Examination Survey. And at this time, they ended up looking at DSM-4 diagnostic criteria based on parent report. And she asked two questions. One is childhood lead exposure in 8 to 15-year-old children a risk factor for the diagnosis of ADHD? And is prenatal tobacco exposure when the mom smoked? And so looking at the lowest to the third tertile of exposure, you can see that the shift in symptoms, the mean shift in symptoms from one ADHD symptom to 3 ADHD symptoms in the lowest versus the highest tertile of lead exposure isn't all that striking, right? From one ADHD symptom is a mean to 3. Typically, a child with ADHD will have about 15 ADHD type symptoms, right? That's sort of the typical child. So it doesn't seem like that's a big of a deal, right? But if you look at those, that shift in the population mean of those two groups, you can see it's about a 2 to 2.3 fold increase from 5% to 13% in those with lowest to the highest exposure. But we can do the same thing and add tobacco into the mix, and you end up with about a similar odds ratio. But here's where we combine them. So this is where children have both high lead exposure and were prenatally exposed. Yeah, you got it. I saw that. Children with both exposures met criteria for ADHD. When we did this, and I'm sure you've had this experience when you come out with a study you think is important. It's like, wow, this will change everything. Actually, Herb Needleman had that same idea. Remember that study I showed you a couple? He thought, well, this is going to change everything. And he realized a week later, it changed almost nothing, at least not in the short term. People dismiss it most of the time, probably not even reading it. All right, lead exposure and coronary heart disease. I wanted to spend a little bit of time. I don't know how many of you are focused on children, but this is what Ellen Silbergeld was telling me I had to do. I tried to get other people to do it. When I served on the National Toxicology Program's monograph on lead, 2012, we were asked to determine whether at various levels of lead in blood, lead was a risk factor for IQ deficits, for ADHD, for conduct disorder, for hypertension, for coronary heart disease. And we said yes, yes, yes for all of those initial ones. But somebody who was very compelling and done more work certainly than I had on heart disease said, no, we don't have enough evidence that lead's a risk factor for atherosclerosis or coronary heart disease. Now, I didn't agree with that, but I hadn't studied it. I hadn't listened to Ellen. So the next year, the EPA Science Advisory Board on lead, the lead NAAQS, Lead National Ambient Air Quality Standard, did conclude that lead was a causal risk factor. Let me ask you a question though. How many of you would say that coronary heart disease has risen, stayed the same, or declined in the past 50 years? Coronary heart disease deaths have declined by 70% since 1968. I love that look. That's great. That look is sort of like, I imparted some information. It's come down by 70%. Now, here's the thing, and I think this is why most people get it wrong. Typically, when I talk to physicians, a third say it's stayed the same, third say it's decreased, and a third say it's increased. Coronary heart disease is still the leading cause of death in North America. It's now become the leading cause of death worldwide. Why? Well, there's not one single reason, and I'll inoculate myself right now to say there's lots of reasons, but I'm going to be focused on lead. So here's the familiar litany of risk factors: sex, obesity, smoking, diabetes, salt intake, physical activity, genetics, susceptibility. And the way that coronary heart disease kills people mostly is heart attacks, right? And what precedes a heart attack? Typically precedes a heart attack, let's say in about 70% of cases. It sounds almost spiritual. Plaque rupture, plaque rupture. So plaque rupture, you've got that like a pus on the inside of the arterial wall, and something leads to a rupture where it's that grumous material is released into the lumen, and it could be vigorous sex. Like, what a way to go, right? It could be cocaine. It could be air pollution. The idea of cocaine, there's a beautiful study, and it happens to be done by people who are rented. It's always bothered me, but it's a beautiful study. And they looked at population attributable factors for plaque rupture. If you use cocaine in the past 24 hours, you're at about 23-fold increased risk for plaque rupture and a heart attack. Big downside. Plaque rupture. So what about air pollution? Air pollution only increases the risk about 10%. So what should we focus on? Cocaine or air pollution? Everybody's exposed. About 1% or less of people use cocaine. Everybody's exposed to smoking. And when you look at the population attributable fraction, which is actually where you're going, cocaine is responsible for less than 1% of all plaque ruptures and heart attacks. And air pollution is probably higher. They measured air pollution two ways: highway traffic, increased in 10 microgram per cubic meter, probably above 10%. So we have begun to realize that there are other things besides that familiar litany of risk factors. These are lifestyle choices, right? Remember when David Satcher, the US Surgeon General, said 50% of all chronic disease is because of your lifestyle choices, right? It's convenient. Government didn't have to do anything. Industry doesn't have to do anything. It's all on you. But we started to recognize that air pollution that you can't control is also important. Well, then this meta-analysis came out, 2018, and they found that not only lead, but other metals appear to be important risk factors for various types of coronary heart disease. If you focus on lead for just a moment, cardiovascular disease, coronary heart disease, and stroke, boom, 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 right? So this is a meta-analysis. And so we should put toxic metals on that list. Now, if you ask most people, they won't even be familiar with it. I'm not really blaming them unless they start telling me it's not a problem and they haven't read the literature, but most people haven't been familiar with this. The American Heart Association just this year acknowledged it, so about 10 years after the EPA Science Advisory Board did, so it's starting to be recognized. And back in 2012, this is what I was made familiar with. Lead enhances atherosclerosis in laboratory studies by inactivating nitric oxide, inhibiting endothelial repair, that single cell lining of the arteries, repairing angiogenesis, and promoting thrombosis. That's atherosclerosis. Now, I'm not suggesting that lead is the only cause. In fact, the other metals probably, and there are absolutely other risk factors that work together. But no studies then had calculated the number of CD deaths in the US attributable to lead, and it was unknown if these lower blood lead levels are associated with cardiovascular mortality. So after trying for 5 or 6 years to get somebody else to do this, because I studied children. Children don't typically die. I didn't know how to do these studies. I mean, I kind of had an inkling, but I couldn't get anybody to do it. I mean, there are hundreds, maybe thousands of studies looking at air pollution and cardiovascular disease or total mortality, but nobody was doing lead. It is harder to do. You have to have a blood lead measure. You can't rely on the air monitors in your city that are all around the world. So it was harder. So we decided to try to do this. We took advantage of the NHANES mortality follow-up study In this case, they were recruited between 1988 and 1992, and fortuitously, they were focused on heart disease during NHANES 3, during that particular NHANES survey. Over 19.5 years of follow-up, over 4,000 participants died, 1,800 were due to cardiovascular disease, and of those cardiovascular diseases, 988 were due to ischemic heart disease or coronary heart disease. I'm going to use those a little interchangeably. The geometric mean blood lead level of the participants was 2.7, and about 20% had blood leads above 5. And we saw this familiar dose-response relationship. Now it's flipped over, right? But this is basically that same decelerating dose response, but now we're looking at a steep increase in risk that flattens out. How is that important? Absolutely. And if you want some background, and if you want to know what I think is the most important book you should be reading, if you're interested in public health and prevention, you go to the same place, Jeffrey Rose Strategy for Preventive Medicine. So he has a chapter on why dose response is so important. And most of you probably already have an inkling if you're not really familiar with why it's important. So this was for cardiovascular disease mortality. When we looked at coronary heart disease or ischemic heart disease mortality, you can see it's even steeper. And we think the connection is stronger between lead and coronary heart disease than it is with all types of cardiovascular disease. So we expected this. All right, now when we look at the hazard ratio for all-cause mortality, cardiovascular disease mortality, and ischemic heart disease mortality, you can see for the entire population that we studied, about a 40% increase for all-cause mortality, 70% for cardiovascular disease, and a doubling for ischemic heart disease. We also saw a similar pattern when we looked at those adults with blood lead levels less than 5. 5 microgram per deciliter is still sort of viewed as an acceptable level. We won't call it safe, but it's acceptable because it's convenient, I guess. But here's the punchline. So what we estimated back in 2018, all-cause mortality, that lead exposure in the United States accounted for 400,000 deaths every year. We didn't focus as much on all-cause mortality. We wanted to focus on those things where we thought the mechanistic link was stronger. So 250,000 deaths from cardiovascular disease, 185,000 from ischemic heart disease. Wow. That makes lead the leading risk factor for cardiovascular disease mortality in the United States. And nobody knew about it. Not really. And guess what? New York Times didn't pick up on it. They did cover the guy that got the organ. Remember the human organ grown in a pig? They covered that, didn't they? They covered it 2 weeks later when the guy died, but they didn't cover this. Anybody know something?
Lead is also a risk factor for coronary heart disease. That's when your heart is slowly or suddenly suffocated by an obstruction of the arteries feeding the heart. In a national study, we found that deaths increased sharply at blood lead levels below 50 parts per billion, the level considered safe. There was no threshold or safe level. If we let the narrowing of this coronary artery represent the risk of dying from heart disease, you can see that most of the narrowing occurs below 50 parts per billion. We found that lead accounts for about 185,000 deaths every year. That makes lead the leading cause of fatal heart attacks in the United States.
So about 60 or 70 years ago, there was this monumental decision made by our governments and our regulatory agencies. For non-carcinogens, there are safe levels or thresholds. That's how our non-carcinogenic toxic chemicals in our environment are regulated for the most part. And guess what? There's very little evidence to support it. It was just a big assumption. It was a guess. It was convenient, but it was a guess. And maybe it was a reasonable one. But now we've seen that it's not true for lead and asbestos and PM2.5 and benzene. All of those exhibit a decelerating exposure response relationship. And for other chemicals, PBDEs, organophosphate pesticides, most of the others I'm familiar with, there's no threshold. There may not be a nonlinear relationship, It may be linear down to as far as we can measure. There's very little evidence that there are thresholds or safe levels, but that's how we continue to regulate it. Why? Because it's convenient. We don't want to upset the economic order or the social order for that matter. There was a study published last year by a South African master's student who's since moved to Canada, Leanne von Strip, and I'm not sure I'm pronouncing that right. Has anybody heard of endothelial dysfunction? Endothelial dysfunction is how atherosclerosis starts. It's a thickening of the endothelial cell walls. Something damages the endothelial cell. Something recruits inflammatory cells and macrophages that become foamy macrophages, inactive, not very effective macrophages, and other GRA-DU. In a study by a petroleum chemist, somebody funded by the petroleum industry back in the 1970s, 1975, I think it was, Barry, he looked at the total body burden of typical Britons. In men, it was about 165 milligrams. That's about a paperclip in their total body. So he took their bodies after they died and cremated and 165 milligrams. Women's were about 10%, 30% lower. Lead poison men were about 3 times greater than the typical men. Think of that, 3 times, only 3 times. Remember what we said at the beginning? In the 1970s, our blood levels were 1,000 times higher than pre-industrial humans. And the difference between a typical man and a lead poison man was 3-fold. Not a lot of room for comfort, is there? Well, what she found with both lead and cadmium was that if you added very low concentrations of these metals to endothelial cells and tissue culture, is she started to see tears and blebs on electron microscopy. Now that makes a lot of sense. I mean, I'm kind of a simple epidemiologist. Wouldn't it make sense if there was something that led to tears in the endothelial cells, particularly at the bifurcations? That then it's kind of like a pita pocket, isn't it? And then what gets trapped under the endothelial cells and then infiltrates the endothelial cells? Lipids, white cells, inflammatory cells, GRA-DU. And you remember that study I showed you from, I talked about from Britain in the 1970s? He found in men, but not women, that the highest concentration in soft tissues, in all tissues, it was in the bone. In soft tissues, the highest concentration for men and women was in the aorta. And for men, the highest concentration was in the atheroma, the early plaque. So all of this sort of makes sense. The master's student, isn't that cool? I'm not sure anybody else has really noticed this, but it's really neat when you see what I think is, so this is the typical exposure 2016 in the United States. All right, so we talked about how coronary heart disease declined, and you can see here in the United States in red, coronary heart disease deaths were declining from around 1968, but they didn't change at all in Britain. Jeffrey Rose, who I talked about, wrote the Strategy for Preventive Medicine, was convinced that coronary heart disease deaths were on the decline, and he was convinced that meant that coronary heart disease was preventable. In Britain, then, he said, we are failing to prevent a preventable disease, but nobody knew why. There was something called the Decline Conference, 1978, to try to understand why coronary heart disease was declining. Nobody really understood. Well, if you follow that out, you can continue to see in the United States that lead exposure in red continued to decline, as did coronary heart disease deaths. Now, that's not to say that lead is the only contributor. Air pollution probably contributed. In fact, we can't separate out at that time lead and air pollution because air pollution was leaded. Smoking declined. If you smoke, your blood levels are 20% higher than non-smokers. Cadmium comes to play too. That metal also can damage the endothelial cells. If you're a non-smoker exposed to secondhand smoke, your blood levels are 20% higher than a non-smoker not exposed to secondhand smoke. So I'm increasingly thinking about these as more of a continuum: tobacco, air pollution, lead, and other metals. In Britain, they didn't see a decline in coronary heart disease until the mid-1980s, even though air pollution had come down quite a bit before then. But they didn't start to take lead out of gasoline until the mid-1980s. In the United States, we started in the mid-1970s. How many of you knew that there was a precipitous decline in hypertension in the United States among American adults? Precipitous. It went from about 1 in 3 American adults having a blood pressure greater than 140/90, 1 in 3, about a decade later, 1 in 5. 40% decrease. It's huge. There's only been a few people that have tried to explore it, and they concluded that it wasn't because of differences in antihypertensive treatment. There wasn't that much antihypertensive treatment at the time. It wasn't because of smoking, although I think there might have been some contribution from smoking. It wasn't because of obesity or BMI, was it? Because what was happening? Yeah, absolutely. It was on the increase. In fact, they had to use a different blood pressure cuff in NHANES 3 than NHANES 2 because people were becoming so big. So even though obesity was on the rise, hypertension's going in the opposite direction. But what the hell happened? Kind of a giveaway, isn't it? That was when lead was being taken out of gasoline. Now, this is unadjusted, but, you know, increasingly, I'm more interested not in trying to get down to the proving it to the nth degree. Story is actually more important than science. Science is important, don't get me wrong. But why is it that we've been putting so much money into genetics over the past 20 years with very little to show for it? It's not because the science was better. It was because you were convinced, we were all convinced, I wasn't convinced, I'm always been a bit contrary, that genetic therapy, genetics is going to solve our problems. It has not, and it could not. But the story drove the investments. So science is absolutely important, but the story is actually more important. How do we invest in research? What type of research? The story. How do we decide what research to pay attention to and what research to ignore? The story. All right. I taught this past summer for the first time a class on population health research. Population health research. You know, I love it, but population health research, why would you want to take a course, especially in undergrad, in population health research? So I called it Rose's Radical Ideas. And I told the students by the end of the course, it was 4 weeks, 9 hours a week for 4 weeks in the summer. Then they'd have the whole summer off. I'd have the whole summer off. That by the time we finished the class, they would all be prevention wizards. One of the things, and we use Jeffrey Rose's textbook, one of the things that Jeffrey Rose said is, given the average level of blood pressure in a particular population anywhere in the world, one can infer precisely the prevalence of hypertension. He predicted, and Jeffrey Rose didn't believe air pollution was a problem. He didn't know much about lead, although he did ask why lead might be a risk factor with Plummo solvent lead lines. We can come back to that if you want. He predicted that a 5-point reduction in systolic blood pressure would result in 33% fewer people with hypertension. So in that example I just showed you, from 1976 to 1994, systolic blood pressure dropped 5 points in American men, 6 points in American women, and consistent with Rose's prediction, hypertension declined by 40%. I think that's pretty cool. He didn't even think or know that air pollution or lead was a problem, and he could predict this. That's a wizard, isn't it? All right, the global burden of disease. So last summer, last September, a year ago, 2 economists from the World Bank took our study and another study from Columbia University, and they estimated the global burden of disease. I already mentioned, but 1 out of 3 kids has a blood level over 5 microgram per deciliter around the world. Why? Because when we got rid of lead in gasoline and lead in canned foods and lead in paint in the United States and Canada, I was trying to be nice, but the companies marketed it to industrializing countries. And even as heart disease has been declining in Europe and in North America, it's been on the increase, predictably, in industrializing countries. So IHME estimated as recently as 2019, I went to IHME in 2016 and said, look, would you guys do this study, the one that I just talked about? I couldn't convince them. So I ended up having to do it. They still haven't adapted, although they are trying to catch up. World Bank estimated using those two studies I mentioned that there are 5.5 million deaths every year from lead around the world, from heart disease. That doesn't include chronic kidney failure, which would add to that. 765 million IQ deficits for a total cost of $6 trillion, which is equivalent to 5.3% of global GDP and almost 8% of low to middle income GDP, because that's where 90% of the damage is happening. We know what to do. This is what happened in the United States, all these different policies that led to the decline in blood lead level. Across the world, we need to continue the total elimination of lead paint. Those countries in kind of a reddish color continue not to have policies banning the use of lead paint, which means they keep sneaking through, but we know what to do. The advocacy groups working on this said, look, if you give us $15 million in 5 years, we can get rid of all the lead paint in the world. I think they're going to get the money. Leaded gasoline, of course, for the most part is gone, but it's still in leaded aviation fuel in some small aircraft. We did a study 2 years ago, Sammy Zarin, Christopher Keys and I, that looked at lead exposure in children around an airport. We're not measuring the air lead measures. We only have 100 monitors around the United States for lead. We have 3,000 for PM 2.5. The monitors that were used in a small sample around airports don't even pick up small amounts, small particles of lead, which is what comes out of the aircraft. But we found that kids who lived within a half a mile had blood lead levels 11% higher than those who lived further away. If kids lived downwind, had blood lead levels 25% higher, and these could be additive in some cases. So we still have a problem there. I'm almost finished. I got to speed up here just a little bit. Of course, we know that glazed pottery can be a problem, and it is in Mexico. And in some countries, adulterated spices like what was found in Bangladesh, and a really brilliant public health story where they were able to work with the government to get rid of it, and blood lead levels plummeted within a very short time. So we know what to do. We don't need any more expensive studies to make a lot of benefit. We'll need some more research, of course, but we can do a lot. So these are some of the steps that we can take. We could set an aspirational goal for all children to achieve a blood lead level less than 1 microgram per deciliter. Maybe you could make it a little different, but we need a goal. We need to eliminate all non-essential uses of lead. Denmark did this 2 decades ago. We can do it too. And we need to establish empirically derived health-based standards, not what somebody thinks is feasible, but what's based upon reality. In screening older housing, before purchase or occupancy in a city like Philadelphia would be really nice. That was why I was so excited as a postdoc to do that study, because then, and still today, you know how we protect kids from lead hazards? Well, not very well. We let a kid live in a home and then we test their blood, and if they're poisoned, we go, oh my God, it's happened again. We need to go into their homes. We should be testing the homes first. We should be testing the water first. We should be taking it out of the cinnamon before it puts in the food. Those kinds of strategies would be much more cost effective, and we'd actually be protecting kids. When exposure is collective, Jeffrey Rose said, and unavoidable, like air pollution, like lead exposure, only collectively enforced controls can be effective. We will continue to need to do national surveillance for lead, like within Haines. We will still need to do targeted screening of children, or maybe I should say targeted testing of children, but the emphasis should absolutely not be on lead poisoning as a medical problem. It's an environmental problem. It's an environmental justice problem. We should be taking the exposures we know are out there and eliminating them. We know what to do. Thank you.